Assessment of scapular abduction and upward rotation begins with the patient seated with hands in their lap. The patient raises their arm to approximately 130 degrees of flexion, with the elbow extended. The scapula should upwardly rotate, with the glenoid facing up, and abduct without winging. The therapist provides resistance on the arm proximal to the elbow. The other hand palpates the edges of the scapula at the inferior angle and along the vertebral and axillary borders to assess motion.
Raise your arm forward over your head. Keep your elbow straight. Hold it. Don't let me push your arm down.
The Grade 2 test for scapular abduction and upward rotation begins with a patient seated with their arm flexed above 90 degrees. Support for the arm is provided at the patient's elbow. The therapist's other hand lightly grasps the inferior angle of the scapula to assess motion. The presence of scapular winging is monitored.
Hold your arm in this position. Now let it relax. Now hold your arm up again. Relax.
If the scapula does not abduct and upwardly rotate when the patient attempts to hold the arm in elevation, then the therapist palpates for a contraction of the serratus anterior along the axillary border of the inferior angle of the scapula. The patient attempts to hold their arm in the test position.
Try to hold your arm in this position.
The test for grades 5 and 4 scapular elevation begins with the patient seated, hands relaxed in their lap. The patient elevates or shrugs both shoulders simultaneously, while the therapist provides resistance to the shrug in a downward direction. Symmetry of movement is observed.
Raise your shoulders towards your ears. Hold it. Don't let me push them down. Relax.
The Grade 3 test for scapular elevation is similar, except that no resistance is given. The patient is asked to elevate their shoulders through full range of motion while the therapist observes.
Raise your shoulders towards your ears and relax.
For the gravity minimized test for scapular elevation, the patient can be either prone or supine. If prone, the head is turned to one side for patient comfort. The therapist supports the test shoulder in the palm of one hand, while the patient elevates the shoulder toward the ear. The therapist palpates the upper trapezius near its insertion above the clavicle. Alternatively, the muscle can be palpated adjacent to the cervical vertebrae.
Raise your shoulder toward your ear. Relax.
Scapular adduction is assessed with the patient prone and their shoulder at the edge of the table. The shoulder is abducted to 90 degrees and the elbow is flexed to a right angle, or can remain extended. The head may be turned to either side for comfort. There are two ways to give resistance to the scapular adductors. The decision as to which technique to use depends on the strength of the posterior deltoid. When the posterior deltoid is grade 3 or better, then downward resistance is given over the distal end of the humerus. The therapist should stabilize the contralateral scapular area to prevent trunk rotation. When the posterior deltoid is grade 2 or less, then downward resistance is given over the shoulder joint. This more proximal placement of resistance requires less scapular adductor muscle strength by the patient than is needed in the test previously described. The therapist still needs to stabilize the contralateral scapular area to prevent trunk rotation.
Lift your elbow towards the ceiling. Hold it. Don't let me push it down. Relax.
When assessing scapular adduction for grades 2 and below, the starting position is similar, except that the therapist cradles the patient's shoulder and arm, thus supporting its weight. The middle fibers of the trapezius are palpated as the patient attempts to horizontally abduct the arm and adduct their scapula.
Try to lift your elbow toward the ceiling. Relax.
The gravity-resisted test for scapular depression and adduction begins with the patient prone and the test arm in about 145 degrees of abduction, approximating the line of pull of the lower trapezius fibers. The thumb is pointing toward the ceiling, and the head is turned to either side for comfort. The patient raises their arm from the table to at least ear level and holds against resistance. The therapist pushes downward over the distal humerus. The therapist may need to stabilize the contralateral scapular area to prevent trunk rotation.
Raise your arm from the table as high as possible. Hold it. Don't let me push it down. Relax.
The gravity-minimized tests for scapular depression and adduction use a similar starting position, except the therapist supports the patient's arm under the elbow. The patient attempts to lift their arm from the table while the therapist palpates for activity in the lower fibers of the trapezius. If weakness of the posterior and middle deltoid prevents the patient from lifting their arm, the examiner should lift and support the weight of the arm.
Try to lift your arm from the table past your ear. And relax.
Testing the strength of the scapular adductors and downward rotators begins with the patient prone, head turned to either side for comfort. The shoulder is internally rotated, the arm adducted across the back, the elbow flexed, and the hand resting on the back. When the shoulder extensor muscles are grade 3 or above, the hand used for resistance is placed on the humerus just above the elbow. The patient lifts the hand off the back, while maintaining the same general arm orientation. The examiner applies resistance in a downward and outward direction. The other hand palpates for the rhomboids deep under the vertebral border of the scapula. When assessing scapular adductors and downward rotators for grades 2 and below, one option is to have the patient remain prone. The test begins with the patient's shoulder abducted approximately 45 degrees, the elbow flexed about 90 degrees, and the hand on the back. The therapist supports the test arm under the shoulder while palpating for the rhomboids deep under the vertebral border of the scapula. The patient attempts to lift their hand from their back.
Lift your hand, hold it, don't let me push it down, and relax.
Try to lift your hand away from your back. Relax.
The gravity-resisted test for shoulder flexion begins with the patient seated, arms at their sides, elbows slightly flexed, and forearm pronated. The patient flexes their shoulder to 90 degrees without rotation or horizontal movement. The scapula should be allowed to abduct and upwardly rotate. The therapist provides downward resistance over the distal humors. The other hand stabilizes the shoulder.
Raise your arm forward to shoulder height. Hold it. Don't let me push it down. And relax.
Assessment of shoulder flexion for grades 2 and below begins with the patient seated, arms at their side. The therapist palpates the anterior deltoid as the patient attempts to flex their shoulder to 90 degrees.
Try to raise your arm and relax.
There are 3 shoulder extension tests for grades 5 and 4 that should be used routinely. The first is the traditional way of testing shoulder extension in the prone position, and the starting posture can also be used to assess lesser grades of shoulder extension. The other 2 tests are used to isolate the latissimus dorsi to the extent possible and to simulate a more functional movement. The first test is initiated with the patient prone, arms at sides, and their shoulder internally rotated, that is, their palm up. The patient raises their arm off the table, keeping their elbow straight while the therapist applies resistance over the posterior arm just above the elbow.
Lift your arm as high as you can. Hold it. Don't let me push it down. And relax.
So it's the same thing.
This test position can also be used to assess shoulder extension for grades 3 and below by having the patient attempt to raise their arm as high as they can off the table. The examiner palpates for activity in the key muscles including the posterior deltoid, teres major, and latissimus dorsi. The second test for shoulder extension isolates latissimus dorsi function. It begins with the patient prone, head turned toward the test side, arms at side, and their shoulder internally rotated, that is, their palm up. The test shoulder is hiked to the level of the chin. During the test maneuver, the patient depresses their arm and shoulder caudally, leading to an approximation of the rib cage and pelvis. The therapist resists this motion using two hands which are placed around the forearm.
Reach towards your feet. Hold it. Don't let me push your arm towards your head. And relax.
This test position can also be used to isolate latissimus dorsi activity for grades 3 and below. The patient attempts to push their arm toward their feet, while the examiner palpates the latissimus dorsi on the side of the thoracic wall below and lateral to the inferior angle of the scapula.
Reach down toward your feet and relax.
The final test for shoulder extension starts with the patient seated, with hands flat on the table, adjacent to their hips. If the patient's arms are too short to assume this position, a push-up block can be provided for each hand. The patient pushes down through their hands, lifting their buttocks from the table. The therapist palpates fibers of the latissimus dorsi on the lateral aspects of the thoracic wall, bilaterally, just above the waist.
Raise your bottom off the table and relax.
Scaption is arm elevation in the plane of the scapula, about halfway between shoulder flexion and shoulder abduction. This motion is more functional than either forward flexion or abduction. Assessment of scaption begins with the patient seated. The patient elevates their arm halfway between flexion and abduction. The therapist applies downward resistance just above the elbow. For stronger grades, the therapist may need to stabilize the shoulder. For lesser grades, palpation over the anterior surface of the shoulder will assist in detecting muscle activity in the anterior deltoid, middle deltoid, and supraspinatus.
Raise your arm to shoulder height, halfway between straight ahead and out to the side. Hold it. Don't let me push it down. And relax.
Assessment of the shoulder abductors begins with the patient seated, arm at side, and elbow slightly flexed. The patient abducts their arm to 90 degrees. Downward resistance is applied just above the elbow. The therapist may need to stabilize their shoulder.
Lift your arm out to the side to shoulder level. Hold it. Don't let me push it down. And relax.
Grade 2 shoulder abduction can be assessed with the patient seated. As the patient attempts to abduct their arm, the therapist palpates for activity of the deltoid lateral to the acromial process on the superior aspect of the shoulder. The supraspinatus can also be monitored. Fingers palpate deep under the trapezius in the supraspinous fossa of the scapula. When assessing grade 1 or grade 0 shoulder abduction, the therapist cradles the test arm with the shoulder in about 90 degrees of abduction. The patient tries to maintain their arm in this position while the therapist palpates for abductor muscle activity.
Try to hold your arm in this position and relax.
Testing of shoulder horizontal abduction begins with the patient prone, shoulder abducted to 90 degrees, forearm off the table's edge, and elbow flexed. The patient horizontally abducts their shoulder against the clinician's downward resistance, which is applied just above the elbow.
Lift your elbow toward the ceiling. Hold it. Don't let me push it down. And relax.
For grades 2 and below, shoulder horizontal abduction is assessed with the patient seated. The therapist supports the forearm. Palpation of the posterior deltoid confirms muscular contribution to the motion.
Move your elbow backward and relax.
The clavicular and sternal heads of the pectoralis major are the prime contributors to shoulder horizontal adduction. The muscles can be tested together or separately. In patients with a cervical spinal cord injury, each head should be assessed separately due to differences in nerve root innervation. All gravity-resisted tests begin with the patient supine. When simultaneously testing both heads of the pectoralis major, the patient's shoulder is abducted to 90 degrees, and the elbow is flexed to 90 degrees. The patient horizontally adducts the shoulder through available range. If tolerated, the examiner provides resistance just proximal to the wrist, opposite the direction of motion, while the other hand palpates for pectoralis major activity, just medial to the shoulder joint.
Move your arm across your chest. Hold it. Don't let me pull it back. And relax.
When assessing the clavicular head, the patient begins with the shoulder in 60 degrees of abduction and the elbow flexed. The patient then moves the arm diagonally up and across the body. The examiner applies resistance above the wrist in a downward and outward direction. The clavicular fibers of the pectoralis major are palpated under the medial half of the clavicle.
Move your arm up and in. Hold it. Don't let me pull it down. And relax.
Assessment of sternal head function begins with the shoulder abducted about 120 degrees and the elbow flexed. The patient moves the arm diagonally down and in toward the opposite hip. Resistance is given at the wrist in the opposite direction. The sternal fibers are palpated on the chest wall at the lower anterior border of the axilla.
Move your arm down and in. Hold it. Don't let me pull it back. And relax.
When the strength of the shoulder horizontal adductors is grade 2 or less, the patient's capacity can be evaluated either supine or seated. In supine, the starting position is again with the shoulder abducted and the elbow flexed approximately 90 degrees. The clinician supports the forearm by gently grasping the subject just proximal to the wrist. The initial angle of abduction and angle of pull will influence which portions of the pectoralis major are activated. Palpation will confirm the muscle's contribution.
Try to move your arm across your chest and relax.
For grades 2 and below, shoulder horizontal adduction can also be assessed with the patient seated and their test arm supported on the table. The arm is placed in 90 degrees of abduction or in scaption, and the elbow is slightly flexed. Friction of the table surface should be minimized. The patient attempts to horizontally adduct the shoulder while the therapist palpates the anterior aspect of the chest medial to the shoulder joint to confirm pectoralis major's contribution. Shoulder external rotation is assessed with the patient prone and head turned toward the test side. For the gravity-resisted tests, the shoulder is abducted 90 degrees with the upper arm supported on the table. The forearm hangs over the table's edge. A folded towel can be placed under the distal arm for comfort. The patient moves their forearm upward through their available range of external rotation. The therapist gives 2 fingers' worth of resistance at the wrist while also providing a counterforce under the elbow.
Raise your arm to the level of the table. Hold it. Don't let me push it down.
The patient remains prone during the gravity-minimized assessment of the shoulder external rotators. The trunk is at the edge of the table so that the entire limb hangs down loosely from the shoulder in neutral rotation with the palm facing the table. The patient attempts to externally rotate the shoulder while the therapist palpates the infraspinatus over the body of the scapula below the spine in the infraspinous fossa. The teres minor can be palpated on the inferior margin of the axilla and along the axillary border of the scapula.
Turn your palm outward and relax.
Shoulder internal rotation is assessed with the patient prone and head turned toward the test side. For the gravity-resisted tests, the shoulder is abducted 90 degrees with the upper arm supported on the table. The forearm hangs over the table's edge. The patient moves the arm through their available range of internal rotation. The therapist provides resistance on the volar side of the forearm just above the wrist. The other hand provides a counterforce at the elbow.
Move your forearm up and back. Hold it. Don't let me push it down. And relax.
The patient remains prone for the gravity-minimized assessment of the shoulder internal rotators. The trunk is at the edge of the table so that the entire limb hangs down freely over the edge, with the palm facing the table. The patient attempts to internally rotate the shoulder while the therapist palpates the tendon of the subscapularis deep in the central area of the axilla.
Turn your arm so your palm faces away from the table and relax.
The gravity-resisted tests for elbow flexion begin with the patient seated with arms at their side. The patient flexes their elbow through the available range. The therapist provides resistance over the flexor surface of the forearm proximal to the wrist. The other hand applies counterforce for stabilization at the shoulder. Varying the forearm position may influence recruitment of select elbow flexors. For that reason, the biceps brachii is tested with the forearm supinated. The brachialis is assessed with the forearm pronated. The brachioradialis is tested with the forearm midway between pronation and supination.
Bend your elbow. Hold it. Don't let me pull it down. Bend your elbow. Hold it. Don't let me pull it down. And relax. Bend your elbow. Hold it. Don't let me pull it down. And relax.
The seated posture can also be used for gravity-minimized assessment of the elbow flexors. The arm is abducted to 90 degrees and supported by the examiner under the elbow and wrist if necessary. As with the gravity-resisted tests, the posture of the forearm influences the muscle emphasized. Palpation can be used to confirm activity in the muscle of interest. For example, as the patient attempts to flex their elbow with the forearm supinated, the therapist can palpate the tendon of the biceps brachii in the antecubital space. Alternatively, the muscle fibers may be felt on the anterior surface of the middle two-thirds of the arm, with the short head lying medial to the long head. When the forearm is pronated, the brachialis can be palpated in the distal arm, medial to the tendon of the biceps. When the forearm is midway between pronation and supination, the brachioradialis can be identified on the proximal volar surface of the forearm, where it forms the lateral border of the cubital fossa. The gravity-resisted test for elbow extension begins with the patient prone, arm abducted 90 degrees, and forearm flexed and hanging over the table's edge. The therapist provides support just above the elbow while the patient extends their elbow to the end of available range or until the forearm is horizontal to the floor. The patient is then moved into slight flexion to avoid locking out at end range. Downward resistance is applied to the distal forearm.
Straighten your elbow. Let it relax a little. Hold it. Don't let me bend it. And relax.
Gravity-minimized tests for the elbow extensors are performed with the patient seated, arm abducted 90 degrees, with the shoulder in neutral rotation and the elbow flexed to about 135 degrees. The entire limb is horizontal to the floor. Support is provided under either the elbow or forearm. As the patient attempts to extend the elbow, triceps activity can be palpated on the posterior surface of the arm, just proximal to the olecranon process.
Try to straighten your elbow. And relax.
Forearm supination is tested in sitting, arm at the side. For gravity-resisted tests, the elbow is flexed to 90 degrees and the forearm is pronated. During the test, the patient supinates the forearm until the palm faces the ceiling. The therapist uses one hand to support the elbow, while the other resists the patient's efforts to supinate. For patients with grade 5 or 4 wrist and hand strength, the therapist can use a handshake grasp to resist supination via the hand grip. When weakness or pain prevents this technique, resistance can be given by grasping the forearm proximal to the wrist. In persons with paralysis, significant motion can occur at the wrist without the forearm pronating.
Turn your palm up. Hold it. Don't let me turn it down. And relax.
During the grade 2 forearm supination test, the patient is seated with 45 to 90 degrees of shoulder flexion and 90 degrees of elbow flexion. The forearm is in neutral. Support for the arm is provided under the elbow. The patient supinates the forearm through available range.
Turn your palm toward your face and relax.
When assessing forearm supination strength for grades 1 and 0, the patient sits with the arm and elbow flexed as for the grade 3 test. The therapist supports the forearm just distal to the elbow and palpates the supinator distal to the head of the radius on the dorsal aspect of the forearm. The patient attempts to supinate the forearm.
Try to turn your palm so it faces the ceiling. And relax. Try and turn your palm so it faces the ceiling. And relax.
The gravity-resisted test for forearm pronation begins with the patient seated, arm at side, elbow flexed to 90 degrees, and forearm supinated. The therapist supports the elbow with one hand. The patient pronates the forearm until the palm faces downward. The therapist resists motion at the wrist. Alternatively, in patients with normal or good wrist and hand strength, the therapist can use the handshake maneuver and resist pronation via the hand grip.
Turn your palm down, hold it, don't let me turn it up, keep your wrist and fingers relaxed. And relax. Turn your palm down, hold it, don't let me turn it up. And relax.
During the grade 2 forearm pronation test, the patient is seated with 45 to 90 degrees of shoulder flexion and 90 degrees of elbow flexion. Support for the arm is provided under the elbow. Starting from neutral, the patient pronates their forearm through available range.
Turn your palm facing outward away from your face. And relax.
When assessing forearm pronation strength for grades 1 or 0, the patient sits with the arm and elbow flexed. The therapist supports the forearm just distal to the elbow and palpates the pronator teres over the upper third of the forearm on a diagonal line from the medial condyle of the humerus to the lateral border of the radius. The patient attempts to pronate the forearm.
Try and turn your palm down and relax. Try and turn your palm down and relax.
While multiple muscles contribute to wrist flexion, two in particular, flexor carpi radialis and flexor carpi ulnaris, play a central role. The function of these muscles is assessed together, as well as separately. To reduce the contribution of the flexors of the fingers and thumb to wrist flexion, patients should keep their digits and thumb relaxed during wrist flexion tests. Gravity-resisted wrist flexion is assessed with the patient seated, forearm supinated, and the wrist neutral or slightly extended. The therapist supports the patient's forearm under the wrist. To test both wrist flexors, the examiner applies resistance to the palm of the test hand. Resistance is given evenly across the hand in a straight-down direction. To test the flexor carpi radialis, resistance is focused over the second metacarpal, or radial side of the hand, in the direction of extension and ulnar deviation. To test the flexor carpi ulnaris, resistance is focused over the fifth metacarpal, or ulnar side of the hand, in the direction of extension and radial deviation.
Bend your wrist up. Hold it. Don't let me pull it down. Keep your fingers relaxed. And relax. Bend your wrist. Hold it. Don't let me pull it down. Keep your fingers relaxed. And relax. Bend your wrist. Hold it. Don't let me pull it down. Keep your fingers relaxed. And relax.
When assessing wrist flexion for a grade 3, the patient is positioned the same as the previous test. For both wrist flexors, the patient flexes the wrist straight up without resistance and without radial or ulnar deviation. For flexor carpi radialis, the patient flexes the wrist in radial deviation. For flexor carpi ulnaris, the patient flexes the wrist in ulnar deviation. The grade 2 test for wrist flexion is performed with the ulnar side of the hand resting on the table. The therapist supports the patient's forearm proximal to the wrist. The patient flexes their wrist with the ulnar surface gliding across or not touching the table.
Bend your wrist, keeping your fingers relaxed. And relax.
The grade 1 and 0 wrist flexion tests are performed with the patient's forearm supinated. As the patient attempts to flex their wrist, An index finger is used to palpate the flexor carpi radialis on the wrist, just lateral to palmaris longus, if the patient has one. Similarly, the tendon of a flexor carpi ulnaris is palpated on the medial aspect of the wrist during attempted flexion.
Try to bend your wrist. Relax. Try to bend it again. And relax. Try to bend your wrist. Relax. Try to bend it again. And relax.
Multiple muscles contribute to wrist extension. 3, however, are the focus of this test: extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. The function of these muscles is assessed together, as well as separately. To reduce the contribution of the finger extensors, patients should not extend their fingers during the tests. Gravity-resisted wrist extension is assessed with the patient seated, elbow flexed, and forearm pronated. The therapist provides support under the patient's forearm. To test all 3 muscles, the patient extends the wrist straight up through full available range without extending the fingers. Resistance is given in a forward and downward direction over the 2nd to 5th metacarpals. To test the 2 radial extensors, the patient extends and radially deviates the wrist, leading with the thumb side of the hand. Resistance is given over the 2nd and 3rd metacarpals in the direction of flexion and ulnar deviation. To test the extensor carpi ulnaris, the patient extends and ulnarly deviates the wrist, leading with the ulnar side of the hand. Resistance is given over the 5th metacarpal in the direction of flexion and radial deviation.
Bring your wrist up. Hold it. Don't let me push it down. And relax. Bring your wrist up and in. Hold it. Don't let me push it down. And relax. Bring your wrist up and out. Hold it. Don't let me push it down. And relax.
The Grade 2 test for wrist extension is performed with the ulnar side of the hand resting on the table. The therapist supports the patient's wrist to minimize friction from the table surface as the patient extends the wrist.
Bend your wrist back. And relax.
Grade 1 and Grade 0 wrist extension tests are performed with the patient's hand pronated. As the patient attempts to extend their wrist, an index finger is used to palpate the extensor carpi radialis longus tendon on the wrist in line with the 2nd metacarpal. The extensor carpi radialis brevis tendon is palpated on the wrist in line with the 3rd metacarpal bone. The extensor carpi ulnaris tendon is palpated proximal to the 5th metacarpal and just distal to the ulnar styloid process. Gravity-resisted tests for metacarpal phalangeal joint flexion can be done either seated or supine, with the forearm supinated and the wrist neutral. The metacarpal phalangeal joints should be fully extended and the interphalangeal joints flexed. The therapist stabilizes the metacarpals proximal to the metacarpal phalangeal joint. The patient simultaneously flexes their metacarpal phalangeal joints and extends their interphalangeal joints. The therapist resists on the palmar surface of the proximal row of phalanges in the direction of metacarpal phalangeal extension. Resistance is given to fingers individually because of the variant strength of different lumbricals. The lumbricals also have different innervations. The patient is not allowed to curl their fingers so as to avoid the possibility of the long finger flexors augmenting motion.
Uncurl your fingers while flexing your knuckles, like this. Relax. Uncurl your fingers. Hold it. Don't let me straighten your knuckles. And relax.
The gravity-minimized tests for metacarpal phalangeal joint flexion are conducted with their forearm and wrist in mid-position. The metacarpal phalangeal joints are fully extended. All interphalangeal joints are flexed. The patient attempts to flex their metacarpal phalangeal joints through full available range while extending their interphalangeal joints. Stabilization is provided at the metacarpals.
Try to uncurl your fingers while bending your knuckles. And relax.
Assessment of strength of the proximal interphalangeal joint flexors begins with the patient's forearm supinated and wrist in neutral. The finger to be tested is in slight flexion at the metacarpal phalangeal joint. Each finger is tested separately. The patient flexes the proximal interphalangeal joint without flexing the distal interphalangeal joint. All other fingers are held in extension by the therapist. The other hand is used to provide resistance against the distal end of the middle phalanx of the test finger. The terminal end of the finger being tested is flicked to ensure that the flexor digitorum profundus is not active. The distal phalanx should be floppy and easily move into extension.
Bend your index finger. Hold it. Don't let me straighten it. And relax. Bend your long finger. Hold it. Don't let me straighten it. Relax. Bend your ring finger. Hold it. Don't let me straighten it. And relax. Bend your little finger. Hold it. Hold it. Don't let me straighten it. Hold. And relax.
To assess the proximal interphalangeal joint flexors for grades 2 and below, the patient's forearm is neutrally aligned to eliminate the influence of gravity on finger flexion. The patient flexes each proximal interphalangeal joint while the therapist provides stabilization and palpates the flexor digitorum superficialis tendon located between the palmaris longus and the flexor carpi ulnaris.
Bend your middle finger. And relax.
Assessment of strength of the distal interphalangeal joint flexors begins with the patient's forearm supinated and proximal interphalangeal joints extended. The wrist must be kept in neutral throughout the test to avoid the tenodesis effect of the wrist extensors. Each finger is tested individually. The patient flexes the distal phalanx of each finger, while the therapist stabilizes the middle phalanx in extension. Resistance is provided on the distal phalanx in the direction of extension.
Bend the tip of your finger. Hold it. Don't let me straighten it. Bend the tip of your finger. Hold it. Don't let me straighten it. Relax.
The position of the patient is similar to the previous test, except that the forearm is neutral to eliminate the influence of gravity. As the patient attempts to flex their finger, the tendon of the flexor digitorum profundus can be palpated on the middle phalanx of each finger.
Bend the tip of your finger and relax.
Gravity-resisted extension of the metacarpal phalangeal joints begins with the patient's arm pronated. Their metacarpal phalangeal joints and interphalangeal joints are in a relaxed, flexed posture. The therapist stabilizes the wrist in neutral. To assess extensor digitorum strength, the patient extends the metacarpal phalangeal joints of all fingers simultaneously, while the interphalangeal joints remain in slight flexion. The clinician provides resistance by placing their index finger over the proximal phalanges. Metacarpal phalangeal extension is not a strong motion, thus only slight resistance is required to break the position. The extensor indicis is tested by having the patient extend the metacarpal phalangeal joint of the index finger while the therapist resists. Similarly, the extensor digiti minimi is assessed by asking the patient to extend the metacarpal phalangeal joint of the fifth digit. The position of the patient is the same as for the previous test, except the forearm is neutral to eliminate the influence of gravity. As the patient extends their metacarpal phalangeal joints, the tendons of the extensor digitorum, the extensor indicis, and the extensor digiti minimi can be palpated as they travel toward their respective digits.
Try to bend your knuckles back as far as they'll go. Relax.
Finger abduction is assessed with the forearm pronated and wrist neutral. The fingers start in extension and adduction. The metacarpal phalangeal joints should be in neutral. The patient is asked to spread their fingers, and the therapist attempts to squeeze pairs of fingers together by applying pressure on the distal phalanxes. For grade 3, the patient can abduct any given finger. Remember that the long finger has 2 dorsal interossei and therefore must be tested as it moves away from the midline in both directions. The first interosseus is palpable at the base of the proximal phalanx. The abductor digiti minimi is palpated on the ulnar border of the hand.
Spread your fingers, hold them, don't let me push them together. Hold it. Hold it.
Finger adduction is tested with the forearm pronated and wrist neutral. The fingers start in extension and adduction. The metacarpal phalangeal joints should be neutral. The therapist grasps the middle phalanx on each of the two adjoining fingers. Resistance is given in the direction of abduction for each finger tested. The therapist tries to pull the fingers apart. Each finger should be resisted separately. The middle finger has no palmar interosseous and hence is not tested in adduction.
Hold your fingers together. Don't let me spread them apart. Hold it. Hold it. And relax.
The thumb's metacarpal phalangeal joint flexion test is assessed with the patient's forearm supinated and wrist neutral. The patient flexes the metacarpal phalangeal joint of the thumb while keeping the interphalangeal joint straight. The therapist stabilizes the first metacarpal firmly to avoid any wrist or carpo-metacarpal motion. One finger resistance to metacarpal phalangeal flexion is provided on the proximal phalanx. Flexor pollicis brevis activity can be palpated either in the tendon or muscle belly, both located in the thenar eminence.
Bring your thumb across the palm of your hand. Keep the thumb in touch with your palm. Don't bend the end joint. Hold it. Don't let me pull it back. And relax.
The thumb's interphalangeal joint flexion test begins with the forearm supinated, wrist neutral, and the metacarpal phalangeal joint of the thumb extended and stabilized by the therapist. The patient flexes the interphalangeal joint of the thumb as the therapist provides resistance to the distal phalanx of the thumb. Flexor pollicis longus activity can be palpated on the proximal phalanx of the thumb.
Bend the end of your thumb. Hold it. Don't let me straighten it. And relax.
The thumb's metacarpal phalangeal joint extension test starts with a neutral forearm and wrist. The therapist stabilizes the first metacarpal firmly, allowing motion to occur only at the metacarpal phalangeal joint. The patient extends the thumb's metacarpal phalangeal joint while keeping the interphalangeal joint slightly flexed. The therapist provides resistance to the proximal phalanx. The tendon of the extensor pollicis brevis is palpated at the base of the first metacarpal, between the tendons of the abductor pollicis and extensor pollicis brevis.
Bring your thumb up so it points toward the ceiling. Don't move the end joint. Hold it. Don't let me push it down. And relax.
The thumb's interphalangeal joint extension test begins with a neutral forearm and wrist at rest on the table. The therapist stabilizes the proximal phalanx of the thumb. The patient extends the interphalangeal joint of the thumb against resistance provided to the distal phalanx.
Straighten the end of your thumb. Hold it. Don't let me push it down. And relax.
The gravity minimized test of the thumb interphalangeal joint extension is initiated with the forearm pronated and wrist neutral. The therapist stabilizes the wrist and fingers while the patient attempts to extend the distal joint of the thumb. The tendon of the extensor pollicis longus can be palpated on the ulnar side of the anatomical snuff box.
Straighten the end of your thumb and relax.
The abductor pollicis longus test begins with the forearm supinated, wrist neutral, and thumb relaxed in adduction.